Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1946, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and around the world. Please note that the opinions and ideas shared on this podcast are of the speakers, and not of the opinions of the Ogden Surgical Medical Society or its board. All medical topics discussed are not to be taken as strict medical advice, and individual clinical judgment is warranted when applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed in regards to their medical practice. Today we are interviewing Jeffery David, DO, PharmD, on exercise for the treatment of emotional diagnosis. Dr. David is the medical director of Weber Human Services and works part-time as an Instacare physician for Intermountain Healthcare. He graduated as a pharmacist in 2009 from Midwestern University College of Pharmacy in Glendale, Arizona. He then worked as a pharmacist for the Kroger Company from 2009 to 2016. During that time, he also attended Midwestern University's College of Osteopathic Medicine and graduated in 2016. Dr. David completed his residency at Intermountain Healthcare's McKay Family Medicine in 2019.
Welcome back to the Ogden Surgical Medical Society podcast. We are excited to bring today's topic, potential roles for exercise in the treatment of emotional disorders, to you, our audience. I'm Kirsten Baca, the Ogden Surgical Medical Society 2024 president. I am a board-certified anesthesiologist and pain medicine specialist, and I practice 100% pain medicine in Clinton, Utah as a solo practitioner with an amazing physician assistant and support team. I am joined by my co-host, Dr. Val Johnson, OSMS board trustee and historian. Dr. Johnson, would you please introduce yourself?
Hello, I'm Dr. Val Johnson. I've been with the Ogden Surgical Medical Society for probably about 65 or more years. I'm the historian. I'm very old, and so I know some of these things by memory, and I try to record the things I think are important. I'm a board certified, I am a retired, but board certified anatomic and clinical pathologist. Thank you.
Thank you, Dr. Johnson. Today, we are lucky to have Dr. Jeffery David, DO, and PharmD with us to talk about an important topic, exercise and its role in the treatment of emotional disorders. Dr. David, let's start with a little background. Not only are you the president of the Weber County Medical Society, but you are also the medical director of Weber Human Services. Can you tell us a little bit about that organization and the population you serve?
Yeah, so thanks for having me. I'm happy to be here. Weber Human Services is a community behavioral health center, and we provide care for primarily Medicaid patients in Weber and Morgan County here in Utah who have mental health or substance use disorders. And so it's a pretty vulnerable population and a group that has a lot of ongoing medical needs in addition to the psychiatric and substance use issues that they're dealing with. And so as a family medicine physician, it's kind of a unique opportunity to kind of delve in both worlds of kind of on the psychiatry side of things and the substance use side of things, along with the physical health ailments that the general population deals with as well.
How did you become involved with the Weber Human Resources organization, and what is your current role there?
So I was a desperate, poor resident, and I was looking for some additional opportunities to moonlight while I was completing my family medicine residency at McKay Hospital in their residency program. And I had had an interest in substance use or the treatment of substance use. Sometimes during residency, I just had a plain interest in substance use, but I resisted that. But I was looking for somewhere to moonlight, and so I dropped in one day after an OB clinic and said that I was interested in working with patients with specifically opioid use disorder and Suboxone, and wondered if they might have a need for some part-time help. And they asked, "Who are you again?" And eventually were kind enough to lead me upstairs and let me talk to their directors and introduce me, and they let me start working part-time as a physician, just moonlighting, working with those patients. And then eventually as I got closer to the end of residency, they said that they had need of a medical director, and I reminded them that I wasn't a psychiatrist, but that I would have an interest in helping this population with their primary care and family medicine type needs in addition to the psychiatric services that were already provided here, and they were agreeable to that, and they've had to put up with me ever since.
So tell us, what makes We Were Human Services different from other community behavioral programs?
So kind of like I alluded to a moment ago, the integration of primary care with regular psychiatric services, case management, therapy, psychiatry, etc., is recognized as a gold standard and something that is to be sought for according to various organizations, but actually establishing a system that's financially viable and able to sustain that integrated care is something that's been a challenge everywhere in the nation. But We Were Human Services was willing to take that on when they hired me as their medical director. So we've been trying to make sure that we have primary care services under the same roof as all of our other services, operating with the same medical record and pharmacy and case management, therapy, residential facilities, et cetera, in-house. And so that's been really successful thus far. And we've been at this now since 2019 and are still alive and kicking and tweaking and figuring things out as we go along to kind of optimize that so that it can be reproducible in other settings. But on average, these folks that have these severe mental illnesses or substance use disorders, they're going to die about 23 years before people without those concomitant problems. And the things that they die from are the COPD, diabetes, hypertension, sequela, and so on, that everybody else dies from. It just happens a lot sooner. And so we're trying to address that to the degree that we're able. And so that makes us really unique in having that in-house primary care clinic associated with us. The other thing that makes We Were Human Services really unique is our emphasis on evidence-based practices for therapy. The previous director of the National Institute of Mental Health, Dr. Thomas Insel, published a book last year in 2022 called Healing. And therein he laments a lot about the inadequate access to effective therapy. He says that access isn't really the problem. It's getting access to therapy that works. There's a lot of, to be blunt, a lot of therapy, just like there's a lot of things in medicine that's nonsense, that doesn't have evidence to show that it's effective. And there's not one governing body that oversees the quality of therapy that's provided. And so people can do a lot of things and call it therapy, just like people can do a lot of things and call it medicine. And so at We Were Human Services, we try to evaluate potential therapy programs that we're considering onboarding for the data that shows that they actually work. And then when we identify a potential type of therapy that we're considering implementing, we go to extensive lengths to coordinate with the organization that developed it, to review their research, and to identify the metrics that they used to measure the efficacy of the treatment and ensure that we're capable of monitoring and measuring those same metrics. And then we go through extensive training with their organization to train us so that we can train our staff to provide the therapy in the same fashion that they themselves did when conducting the research that showed that it worked. And that makes us really original, and there's not a lot of people doing that, and we've advocated on the state level and other governmental levels to try to increase the utilization of that type of practice. And it's been kind of an uphill battle, but we're still here insisting that that's the way that it should be done. And like I said, it was encouraging to hear Dr. Insel agree with that sentiment in his book last year.
What is the name of the specific evidence-based therapy that you're going to discuss with us today?
So the evidence-based therapy, the evidence-based practice that we're talking about today is called the Unified Protocol. Specifically, it's the Unified Protocol for the Transdiagnostic Treatment of Emotional Disorders. When you look at the DSM-5, the Diagnostic and Statistical Manual that parses out how mental illnesses are categorized and identified, there's pages and pages full of boxes that you check to meet criteria for each of these illnesses to determine whether this is generalized anxiety disorder, panic disorder, post-traumatic stress disorder, schizophrenia, or major depressive disorder, or whatever. And they're really pretty specific. But what they found and what's interesting is that many people have more than one mental illness. They might have generalized anxiety disorder and meet criteria for major depressive disorder as well. And when an individual is effectively treated for one of those illnesses with an evidence-based practice or whatever modality, they often find that the other gets better as well. And that would indicate to some degree that, okay, there seems to be some underlying thread that is going through all of these things that is common among them. And what they've found is that there are 3 particular vulnerabilities that patients with any emotional disorder are susceptible to. And regardless of whether that person's dealing with obsessive compulsive disorder or some type of anxiety or depression, et cetera, these 3 things are common. And those vulnerabilities include, number 1, neuroticism, or a tendency to feel increased proclivity or tendency to feel negative emotions. And that leads to the second problem, which is aversive reactions. When people feel those unpleasant, uncomfortable, painful emotions, they have thoughts or sometimes physical sensations, increased heart rate, increased respiratory rate, et cetera, that are so uncomfortable that those aversive reactions then cause them to engage in that third vulnerability, that third problem, which is an avoidant behavior. They do something to escape that discomfort. And that something helps in the short term alleviate the discomfort, but in the long term, it perpetuates it. So you have neuroticism, or frequent, intense negative emotions. You have aversive reactions, thoughts and physical sensations that are so uncomfortable that, third, it will drive them to engage in an avoidant behavior that provides short-term alleviation, but long-term perpetuation of the problem that they're struggling with.
Wow. Okay. So then tell us a little bit more. What is the Unified Protocol then?
So the Unified Protocol is a treatment modality that consists of 12 to 16 sessions wherein a patient meets with a therapist for approximately 50 to 60 minutes. And they do that every week. And the therapist helps them to develop some skills that will help them to combat these 3 vulnerabilities that I previously discussed. And just to kind of reiterate how we would explain that to a patient, when we're talking to a patient, we would often say something along the lines of, the human brain is a prediction machine. It's designed to predict what's going to happen next and help us to prepare for that. And it's been estimated that, at any one time, it's evaluating 11 million, or pick your number, pieces of information at any given moment. But we can only consciously attend to a few things at a time. And so our brain it compares all the data that we're receiving at that moment, compares it to all of our past memories, and then packages that up into a report of sorts, which is the emotion. And it says, based off the current data and our previous memories, I think this is what's going to happen, and I've prepared us to deal with it. So it may be something that invokes anxiety, and it increases our heart rate and our respiratory rate to get us prepared to deal with that. And that then leads to those, again, thoughts and physical sensations that can be pretty uncomfortable. And so then the patient will do something to get away from that. If they have obsessive compulsive disorder, they may wash their hands 50 times to try to alleviate some of that discomfort. They might, if they have anxiety, stay in their room instead of going to their work party, or they might use drugs to blunt that discomfort. And so we want to intervene, and we can't get rid of the emotions, and we don't want to. Those emotions are important and serve to educate and motivate us to be able to handle whatever it is that's coming. So but we do want to be able to handle this better. So some of the skills that can help us with our tolerance of those avoidant reactions and increase our ability to respond with a behavior that's consistent with our values as opposed to the avoidant behavior include the following. So first, we want to foster a mindful awareness of the emotion. We want to help them to develop the capacity to recognize what's going on when they experience an emotion, to be able to identify it and realize what's happening to them. The second core skill, so the second of the 5 core skills, is to be able to reevaluate some of those automatic cognitive appraisals that occur. And the 2 things that the Unified Protocol specifically works on is helping patients to resist overestimating the probability of something negative happening, and second, to avoid catastrophizing, which is the tendency to assume that even if that negative thing does happen, the outcome will be so bad that it'll be unrecoverable. Third, we want to help our patients identify and modify those problematic behaviors or action tendencies, those emotional behaviors that, again, in the short term, alleviate discomfort, but in the long term, perpetuate that problem. And when we're explaining that to patients, we'll often counsel them along the lines of, if we use drugs when we feel this, whatever the negative whatever the aversive reaction is, in the short term, that blunts the sensation. It makes it less uncomfortable. But in the long term, that's going to put us in a bad position, because next time our brain is confronted with those stimuli, if it could speak, it would say something along the lines of, last time we were in this situation, what did we do to fix it? Oh, look, we have a nice fresh memory on the top of our stacks here. It looks like last time we used drugs, or we ran away, or we washed our hands 50 times, or we have obsessive compulsive disorder, or whatever. And so it's going to perpetuate our brain suggesting that we repeat that action to address the situation again, because it worked last time. So we want to help patients be aware of the long-term problems of engaging in those avoidant behaviors. And then the fourth core skill is we want to help them increase their awareness and tolerance of the physical sensations that are uncomfortable. Sometimes when patients start to get an increased heart rate, or they start breathing fast, they become so worried that it's going to get out of control that they'll panic and then again engage in the avoidant behavior. So we want to make them, or help them to become tolerant of physical discomfort and to realize that they're going to make it through that. And then lastly, the fifth core skill is engaging in emotion exposure exercises. So the therapist is going to help the patient systematically identify the things that they're most afraid of, and then help them develop a plan to start exposing themselves to that. And it's kind of gross, but like in obsessive compulsive disorder, that may be using the restroom and then going and eating lunch without washing your hands, and realizing that you didn't die from it and things were okay. Or if you're afraid of going to the grocery store, helping the patient to engage in that again and again and again, or so on and so forth, depending on the individual circumstances.
Those 5 skills that you work on developing, what are some specific examples? You told us the last one of exposure therapy, but what are some specific examples, or maybe patient stories you have for some of these vulnerabilities and where you've helped people?
Here at Weber Human Services, we have residential facilities where we house men and women who are struggling with substance use disorders specifically. And with that patient population, they have a lifetime of memories stored in their mind that suggest each time they encounter any type of difficulty, whether it's the death of a family member or the loss of a job or any type of difficulty, any type of problem in life, those emotions that they experience are so uncomfortable that it causes them to engage in those, or to experience those aversive reactions, the thoughts and physical sensations that are uncomfortable, that they go out and engage in the avoidant behavior of using methamphetamines, heroin, cannabis, etc. And so where we have the most success with patients is helping them to understand that the best thing for you is not necessarily to treat you with a medication to address your discomfort, but to help you to practice enduring that discomfort and to work with you on, in that moment, when you're tempted to choose an avoidant behavior, to choose a behavior that's more consistent with your values and create new memories and new pathways. And that plasticity of the human brain is something that's really helpful for them to understand that just like a muscle can grow with increased utilization, so can their brain, and it can adapt and it can learn to respond differently, and that they're not doomed to stay in the current path that they've been down so many times. As far as a specific example, I can think of lots of patients that have come in and said, thank you for not giving me the sleep med or the anxiety med when I asked, and thank you for insisting that I continue participating in therapy. And it's always rewarding when a mom comes back and says that she got custody of her kids again, and she's able to use these concepts to get her own employment again. I remember a specific patient who she had an abscess that was so uncontrolled in one of her extremities that she almost had to have it amputated. And now she is the manager at where she works. Her company paid for her and her family to go on vacation. She's got her kids back. But helping them to understand that increasing your resilience and your ability to be aware of these things and respond to them differently is more effective in the long term than medication. So as far as, and I've got some examples of how we're trying to start working on implementing exercise to help make some of this a little more concrete, and maybe that'll help if we move on to that.
But what are some actual things, the actions that you do to intervene in those instances to help these people?
So for the first core skill is fostering that mindful awareness. When I was in residency, they taught us about mindfulness, and I remember specifically asking the therapist who was working with us at the time, I said, so wait a minute, you want me to just sit here and listen to my breath and not do anything else, and that's it? And he said, yeah. And I said, that's your plan? What is that going to, how is that going to help me? And I was so, of all the things we had to do in residency, I was so bugged and so annoyed, and I didn't understand, how that would be useful at all. But when you look at that skill in light of the unified protocol, that makes sense. Because if someone can develop the capacity to intentionally focus on whatever, whether it's their breath or something else, that person can pause when they feel discomfort, when they feel that aversive reaction. If they've practiced mindfulness, then in that moment, their ability to push away all the other noise and put their attention on what is going on in that moment increases. And so what we specifically try to help, one of the first things the therapist will try to help them do, Val, is that idea of mindfulness, to have non-judgmental, present-focused awareness, to not get so caught up in what they're assuming is going to happen or what could happen or what might happen, or that they're a loser, that they're bad, but just to pay attention to what's happening. I feel anxious, I feel afraid, I feel angry, I feel whatever. Someone who does that, who practices mindfulness on a regular basis, there have been studies where they've shown that the parts of their brain associated with attention and the parts of their brain associated with the interpretation of pain actually thicken. They develop more gray matter in those areas where their brain processes those concepts. So that really, the therapist in our residency clinic that was teaching this showed me some of that helped me to have a lot better impression of the value of mindfulness and how that can help in the context of the unified protocol to help them pause in that moment when they experience the aversive reaction and not just automatically react with avoidant behavior, but to create a space where they can stop and think, what is going on here? And then they can move on to the next step of reevaluating the situation and what they can or should do next.
What role does exercise play in helping patients learn to cultivate some of these skill sets in treating their emotional disorders?
So if someone experiences that intense negative emotion, whether it's fear or anxiety or depression or whatever, and they're able to use those skills developed in mindfulness, and they're able to pause and recognize what's happening, just to observe it in a non-judgmental, present-focused manner, then the next thing that they need to be able to do is they need to be able to reevaluate the situation, and that's called cognitive flexibility. And so that's the second core skill. And so we want to teach them how to not overestimate that something bad is going to happen and how to avoid catastrophizing. And then the third skill is to identify and modify problematic behaviors and make the decision to choose something different. And then the fourth core skill is to learn to tolerate physical discomfort. Now this is where exercise becomes really helpful, because yes, there's some value in having a patient go to the grocery store once a day or something like that. They can run their errands. If they have really bad agoraphobia, for example, they don't want to go to the grocery store. Getting them to the point where they go to the grocery store once a day or once a week or whatever has some value, but it's limited. And in tolerating physical discomfort, the therapist might have the patient walk up and down the stairs a few times to help them realize that their heart rate going up and their respiratory rate going up didn't lead to something that was fatal or terrifying. But walking or spinning around in a circle to help them tolerate physical discomfort, having to walk them down stairs to learn to tolerate physical discomfort, those things aren't really valuable by themselves. But if you can couple this idea of the unified protocol with exercise, then you can get some really exciting things to happen, because exercise, it has mountains of data to show, obviously, that it's helpful by itself. Regardless of whether you're doing therapy or not doing therapy, it alleviates, prevents, and treats much, if not most, of what we try to preserve and protect in medicine with people's physical health. And so if we can have someone engaged in therapy so they understand these processes that are driving their emotional disorder and causing it to recur, if they understand that, and then we couple it with exercise, that can lead to some exciting things, because exercise allows them a chance to practice being uncomfortable in a systematic way. They're able to experience that aversive reaction. I don't want to do this. If I get under a squat bar, it's uncomfortable. What if the other people in the gym think I'm a wimp or whatever? They get the chance to experience an aversive reaction with every single set that they do, and they get a chance to choose a values-consistent behavior instead of an avoidant behavior with every single set that they do. And the exercise itself, again, is valuable regardless of the therapy. So the unified protocol was developed without linking it directly to exercise, and it worked. It worked really well. And that was with, again, the therapists doing things like having them run in place and whatnot to experience physical discomfort, and with just teaching them about these concepts. But by coupling it with exercise, you can give them a methodic way to practice them again and again and again and again. And over time, their ability to respond to negative emotions in a more constructive way increases, because, again, they experience the negative emotion. They then have an aversive reaction, thoughts and feelings that are uncomfortable, thoughts and physical sensations that are uncomfortable. And when they engage in the exercise again and again and again and again, it gives them a chance to choose a behavior that's appropriate and consistent with their values, and resist the avoidant behavior again and again and again and again.
So I'm just curious. I know that I have a lot of folks that we have a hard enough time doing exercise for good health. How do you get patients to buy in and follow through?
Starting with something that's manageable. We talk about habits that you could marry and not just date, and that at the beginning, the routine is more important than the intensity. The habit is more important than how aggressive you're engaging in whatever activity it is. Ideally, I would like patients to engage in walking or jogging, and then 4 barbell lifts, a squat, a deadlift, a standing overhead press, and a bench press, because those exercises use the most amount of muscle in the least amount of time and have the highest efficiency. They're infinitely titratable, and you can have a 90-year-old 90-pound woman do that, or you can have a 20-year-old, 180-pound young man, and they'll both benefit from it. But for a lot of folks, getting to a gym, getting started with those types of things, that can be intimidating. And so when you look at habits, there's that process of cue, routine, reward, cue, routine, reward. So we'll try to tell them to start. Make it as easy on yourself as you can. Identify what cues are going to indicate your time or will indicate that it's time to do this. So you have to make as few decisions as possible. So at this time, at this place, I do this thing. At this time, at this place, I do this thing. And they may start with just walking around their house once, and then we go up to doing 5 push-ups, and then eventually adding on more and more until hopefully they could get to the ideal of weight training and whatnot. But at the beginning, we tell them that this should be so easy that it feels embarrassing, because at the beginning the habit is more important than the actual intensity of whatever it is that you're doing. And so that's something that's been helpful, is trying to help them to approach it with that type of mentality. There's a program here in Ogden called the School of Addiction Recovery. That's a fantastic organization, and we have hopes of working or partnering with them in the future. They start with weight training right at the beginning, and they have a facility here that's well equipped and they have folks that know how to teach those lifts, and we're still working on trying to get something in the future set up with them to have a more formalized program, and that's kind of down the pipeline a little bit, but something that we're hoping to get to.
You mentioned that you want somebody to start with very low barrier to entry. It should feel so easy, it feels dumb to do, right? Or feels dumb to resist. What is the timeline for habit formation in this case? Does it take, do you do this every other day for a week, every other week for a month, or what is the frequency that people return, and when do you start titrating up the physical resistance to get those core skills developed, or to enforce the core skills?
There was this anecdotal long-term belief that I heard all the time that a habit takes 21 days to develop. I think the most recent research that I had seen on that was actually, on average, it's closer to like 60 days for people to develop habits. But I try to tell people that at the beginning, that it's, this is a multi-week, multi-year, and hopefully indefinite type scenario. But I don't know if there's a one size fits all, like how soon you can titrate up, but just when they're doing it, if they're doing it consistently, then they're ready to move on to the next thing. And so I think that's probably among, the biggest indicators, is just whether or not they're actually doing or trying what you've suggested that they do. And another thing that I've noticed is that it's almost easier to have with exercise, rather than have it be a decision where they're only doing it a couple times a week or 3 times a week. They should have a minimum that they do every day. And on your rest days, you need time to rest, but maybe that's just walking on that day. But it adds complexity and extra work if, when you're trying to, if every day you have to ask yourself the question, is today an exercise day? Well, I don't know. I could do it tomorrow. I only have to do it 3 times a week. Maybe I'll do it. Maybe I'll do it then. Maybe I'll do it Thursday. Maybe I'll do it Saturday. That creates more work. It's kind of like prescribing an anxiety medicine to someone. When you do a PRN anxiety medicine, because when you do that, you put that person in a position where now every single time they encounter something that causes them to be anxious, they have to stop what they're doing and ask themselves, is this an anxiety is this a Xanax worthy situation? Should I take hydroxyzine for this? Oh, I don't know, maybe, but I don't want to be too drowsy. Well, maybe I'll take 2. No, I'm not. You disrupt their day 100, maybe not 100 times, 5 times, 10 times, whatever, because they have to make a decision over and over again every time they encounter a stress. And with exercise, if they don't have a plan of, this is just something I do every day, then every day they have to say, is this an exercise day? And if they don't have a time when they do it, then they have to say, well, when should I do it? And if they don't know what they're going to do, then they have to say, well, what should I do? And the more decisions they have to make, the more work there is for them to do. And that's finite. We've all learned and seen how studies showing that the amount of decisions and willpower that a person can muster in a day is limited. And so at the end of the day, that usually wanes. So what I tell patients to do is I say, we try to set up something that they can do every day. So, you might run or walk 3 times a week, and you might do some type of resistance exercise the other way, run or walk 3 or 4 times a week and do resistance exercises 3 times a week or something like that. And then when are you going to do it? And where are you going to do it? What are you going to do? So that you don't have to make these decisions. They're made in advance, and you've made the decision once and put it behind you. And then you keep doing that thing at that time, at that place. And eventually your brain will start to help you with that same process that we talked about in the unified protocol, because it recognizes, okay, here's the current data. What did we do last time? We were in this time, in this place. And it says, oh yeah, we exercised. So you can use those things in your favor. And that's what we try to encourage.
I just have one more follow-up. I've been taking notes here, but just can you review one more time? What are those 4 bar moves that you said are high impact?
Oh, yeah. So there's a program that I really like the thought process and the evidence behind it. It's called Starting Strength. Mm-hmm. And it's a group that it's a strength training program that has been really well researched. And actually, there's a certification called a starting strength coach. And if you look on Up to Date, for example, and look up weight training, the author of that monograph is a starting strength coach. He's an ER physician, and he'll go through some of these same principles. But with strength training in particular, everybody has a limited amount of time. And so if you want to get the most bang for your buck, the idea is you want to move the most amount of muscle in the least amount of time. And you want to do that in a way that's safe and that's reproducible. And so barbell exercises are perfect for that, because they're infinitely titratable. You can get an aluminum bar with 1/4 pound weights if you need to for that 90-pound woman, or you can get bigger for the young, adolescent male. But 4 lifts that are safe and that are effective for moving the most joints and consequently the most muscle in one time include a barbell deadlift, a barbell bench press, a standing overhead press, and a barbell squat. And if someone can practice those again and again and again and again throughout their life, and it's safer than playing basketball, and a lot of other things that we advocate for when it comes to exercise. And the folks at that starting strength, I don't work for them or anything, but they actually have an app that if someone is really serious and wants to start doing this, I'll recommend to patients. And that it's like $20 or something. And it's a fairly expensive app, but it's really well put together. And that app has videos and portions of their book that'll explain step by step. If you're going to do a deadlift, this is where you put your feet. This is where you put the bar. This is when and how you breathe. The same with a bench press, the same with a standing overhead press, and the squat. And they've got a workout log that you can keep track of your progress in there. And it's really a good program, and makes a lot of sense as far as maximizing that process of stress adaptation response. And that it's part of the reason why I like the unified protocol so much, because oftentimes, when I send someone to therapy, whether it's psychiatric therapy or psychotherapy or physical therapy, I kind of feel like a snake oil salesman, because I don't believe it's going to work. And the reason I don't believe it's going to work oftentimes is because if someone goes to a physical therapist and they bounce on a Bosu ball and they do finger walks once a week, that's not enough stimulus to produce change. That's not enough to cause the person's body to need to really adapt much in most cases. And especially if they're not doing anything at home, they just go once a week, that's not enough. And if someone just goes to the therapist, and even if they go a lot to the therapist, let's say they go every single week, like is recommended in the unified protocol, but they're not doing homework between sessions, that's not enough work. It's not enough stimulus to produce change. And so for something to have a meaningful effect that's going to actually result in something being different in the person's life, they need to have stuff that they can practice on a regular basis during the other 167 hours a week, aside from the one when they're at physical therapy, the one when they're in therapy. And so the unified protocol provides lots of homework for them to do that. And with exercise, it provides something that's, if you couple that with the unified protocol, it's something that's intrinsically valuable by itself, that's going to help them throughout their life with everything else that they do. And it's something that they can do on their own again and again and again, and actually produce enough stress that it results in a physiologic response.
Thank you. Yeah, that's awesome. I think I'm going to go look this up. This ties in really well with last year's conference theme, lifestyle medicine. And I think that it's really important to address the patient in many different ways, especially exercise, good health, diet. We didn't talk about that, but yeah. All right. Thank you. I don't have any other questions. Dr. Johnson, did you have any others?
No, thank you. This was most interesting.
Well, thank you, Dr. David, for joining us today and sharing with us information about the Unified Protocol and about your work at We Were Human Services.
Absolutely. Thanks for having me.
The producers of this show were Clark Madsen, MD and MS, Teresa Puskedra, MPC, and the Ogden Surgical Medical Society Board of Directors. The executive director is Teresa Puskedra. Your hosts were Kristen Baca, MD, and Val Johnson, MD. Editing and sound design were by Owen Service. This is all supported by the Ogden Surgical Medical Society like you. Thank you.